Welcome to a new deep dive. Today we're unpacking a topic that touches so many lives, and honestly it's constantly evolving. Prenatal diagnosis and fetal assessment during pregnancy. We're going to try and make sense of what these procedures actually involve, why they're offered, and the kind of insights they give us into fetal health. Our sources for this journey are excerpts from a really authoritative ebook chapter on maternal, newborn, and women's health nursing.
Exactly. And the goal here really is to help you navigate what can feel like a pretty complex landscape in modern obstetrics. We want to give you a clear understanding of the tests available and the really crucial role they play in checking on fetal well-being. I mean, these advanced technologies, they've truly opened the door to proactive insight. It gives families this unprecedented window, into their child's health before birth, and that fundamentally changes how decisions get made and how care is approached.
That is a huge shift. So, okay, let's start with maybe a basic distinction we hear a lot. Screening versus diagnosis. What's the actual core difference there in prenatal care?
Yeah, that's fundamental. And what's insightful here is just how different their purposes are. Even though, they're both about information, screening tests are designed to identify individuals who have a higher likelihood of a condition. Think of it like casting a wide net. They're not meant to be 100% accurate. They can give you false negatives or sometimes false positives. They're about assessing risk.
Okay, so risk assessment.
Right. Diagnostic tests, though, they're different. They're much more precise. Their whole purpose is to confirm the definite presence or absence of a specific disease or condition. So if a screening test kind of raises a flag, points to a potential risk, a diagnostic test is often that next step to get a definitive answer, yes or no. And knowing that difference is just crucial for managing expectations.
That makes sense. So a positive screening for something like trisomy 21, it's not saying this is happening. It's saying maybe we need to look closer with a diagnostic test. That clarity must be, well, incredibly important for expectant parents.
Precisely, yeah. And linking this to the bigger picture, these advanced technologies are really all about giving comprehensive information to prospective parents. They help spot genetic disorders or maybe abnormalities that could affect the obstetric client, empowering them with knowledge much, much earlier than before. And that can really impact how they prepare and the decisions they make.
Right. So who actually gets offered this kind of testing? Is it just for people with known risk factors, or is it like offered more broadly now?
Well, in the United States, generally, prenatal testing is offered to all pregnant clients.
Okay, everyone.
Yeah, regardless of age, family history, or their past obstetric history. It's become a universal offering. The process usually kicks off with some initial counseling from the obstetric providers, and then often that's followed by more specialized genetic counseling. And this, it really highlights how important shared decision-making is. Clients are advised, strongly advised, to get really well-informed counseling. They need to grasp the benefits, sure, but also the limitations of every single test. Nurses, for example, play such a vital role here. They help foster clear communication, support clients through what can be, frankly, a really complex set of choices.
Okay, we've sort of laid the groundwork for how these tests fit together. Now let's talk about that first visual, that first window into pregnancy for so many families. Ultrasound. How vital is this tool?
Oh, it's huge. It's truly considered one of the most valuable diagnostic tools we have in obstetrics. Ultrasound just uses sound waves, right, to create images of the fetus, gives us that real-time look, and the technology has just seen incredible advances. We've gone from basic 2D to 3D and even 4D imaging. The 3D and 4D give us this remarkable detail. It helps us identify things like a cleft lip or other structural issues much, much more clearly. And there are different types, different categories of obstetric ultrasound too. You've got your standard or basic limited scans, and then specialized, detailed, or target scans. Each one serves a specific purpose, from just routine checks in a typical pregnancy to really targeted assessments if there's a suspicion of a problem.
Can you walk us through some of the key uses, maybe starting early on in the first trimester? What are you typically looking for then?
Sure. In the first trimester, ultrasound is mainly used to confirm the pregnancy is viable, that there's a heartbeat. It helps determine the gestational age really accurately, evaluate the pelvic structures, and diagnose if there's more than one baby, like twins or triplets.
Okay.
It's also crucial for identifying specific markers, like Nuchal translucency. That's the NT measurement.
Right, I've heard of that.
Yeah, it's a measurement of fluid at the back of the baby's neck. And an increased measurement there can indicate a higher risk for conditions like trisomy 21, Down syndrome, or even things like congenital heart defects. And usually during this early stage, a transvaginal approach gives the clearest picture.
Okay. And then what about later on, second and third trimesters, as the baby gets bigger?
Right, so later on, we usually switch to a transabdominal ultrasound, the probe on the belly. And here, the focus shifts. It's more about a detailed look at the fetal anatomy, monitoring growth, checking the baby's position, and looking carefully for any potential structural abnormalities.
Like what kind of things?
Well, things like spina bifida, where the spinal cord doesn't close properly, or gastroschisis, where some of the baby's intestines might be outside the body. It lets us do a really comprehensive evaluation of the anatomy, the umbilical cord vessels, where the placenta is located, and the amount of amniotic fluid.
Gotcha. Now, I have heard about those 3D and 4D ultrasounds being done just for, like, keepsake pictures outside of a medical setting. What's the professional view on those?
Yes. The keepsake ultrasounds, those are typically 3D and 4D scans done for non-medical reasons, purely for the images or videos. And it's really important for people to understand that the FDA and major professional organizations strongly discourage this non-medical use.
Why is that?
Well, it's not just about being overly cautious. It's because there's simply no medical benefit. And the potential risks of, say, prolonged or unsupervised exposure to that ultrasound energy aren't fully understood. It really boils down to ensuring these powerful medical tools are used responsibly by trained, credentialed professionals, and only when there's a clear medical reason.
Okay, that makes sense.
And nurses, by the way, play such a key role throughout all ultrasound procedures. They help with positioning, scheduling, but also providing that crucial information and emotional support, making sure clients feel informed and comfortable.
So the ultrasound gives us that amazing visual blueprint. But then often, to get the full picture, especially for genetic markers, you combine that imaging with blood tests, right?
Yeah.
Let's talk about first trimester screening.
Exactly. So first trimester screening, or FTS, it's a combined approach. It takes that Nuchal translucency, the NT measurement from the ultrasound, and combines it with blood tests looking for two specific things: serum analytes, PAPP-A, pregnancy-associated plasma protein A, and HCG, human chorionic gonadotropin. Think of these as like biochemical signals. When you combine them with the NT measurement, they give us a pretty good early picture of potential risk.
Risk for what specifically?
Primarily for trisomy 21, 18, and 13, and this is typically done between 10 and 14 weeks gestation. That NT measurement, if it's greater than 3 millimeters or above the 99th percentile for that gestational age,
Right.
That's a key flag for increased risk.
Okay. Now, cfDNA screening cell-free fetal DNA, that sounds incredibly advanced. Analyzing the baby's DNA from the mother's blood, how has that changed early screening?
Oh, it's a total game changer. cfDNA, sometimes called NAPS or NIPT for non-invasive prenatal screening or testing,
Yeah.
it analyzes these tiny fragments of fetal DNA that are just naturally circulating in the mother's bloodstream. What makes it revolutionary is its incredibly high sensitivity and specificity, especially for detecting trisomy 21, Down syndrome, but also for trisomy 18, trisomy 13, and issues with sex chromosomes like Turner syndrome or Klinefelter syndrome. Yeah. It can be done really early as 9 to 10 weeks. And now it's offered to all pregnant clients, not just those considered high risk initially.
That's a big shift.
Huge. And a really fascinating and frankly reassuring aspect for parents is that a false positive result for trisomy 21 specifically is highly unlikely with cfDNA, which means much less unnecessary anxiety and fewer follow-up invasive tests compared to older screening methods.
That's significant. Then moving on a bit, there's the second trimester screening, often called the quad screen, right? What's that looking at?
That's correct. The second trimester multiple marker screening, or quad screen, measures 4 different things in the mother's serum. HCG again, alpha-fetoprotein, AFP, inhibin A, and unconjugated estriol. This test screens for trisomy 21 and trisomy 18, but it also screens for open neural tube defects like spina bifida, mainly by looking at that AFP level. It's usually done a bit later, between 15 and 22 weeks.
Okay, so with all these different options, first trimester, cfDNA, second trimester, how do they actually come together? How does someone navigate this? Are there ways these tests are combined?
Absolutely. The idea is really to optimize the information you get while balancing things like timing, anxiety, and cost. So there are different strategies. You have integrated screening, sequential screening, and contingent screening.
Okay, break those down a bit.
Sure. Integrated screening combines both the first and second trimester results. You do the tests in both trimesters, but you get a single comprehensive risk assessment, usually only after the second part is done. Sequential screening gives you the first trimester results first. Then, based on that, you decide whether to proceed with the second trimester test. Everyone gets offered the second part. Contingent screening is a bit more nuanced. You get the first trimester results, and only if your risk falls into an intermediate category, not clearly low, not clearly high, then you're offered the second trimester test.
I see. So it tailors the process a bit.
Exactly. These different approaches just offer flexibility and different ways for parents to receive and process the information.
Okay, so let's say a screening test comes back, suggesting a higher risk. That's the point where we shift from thinking about probability to needing more certainty. That's where diagnostic tests come in. Let's talk about chorionic villus sampling, CVS.
Right. CVS, chorionic villus sampling, is an invasive diagnostic procedure. It's not a screening test. What it involves is taking a very small sample of tissue from the placenta. These tiny microscopic projections called chorionic villi. It's usually done earlier in pregnancy than other diagnostic tests, typically between 10 and 13 weeks. And it can be done either through the abdomen, transabdominally, or through the cervix, transcervically.
And what's the main advantage?
The biggest advantage of CVS is getting those diagnostic results earlier in the pregnancy compared to, say, amniocentesis. It's used to diagnose chromosomal abnormalities like Down syndrome, but also specific metabolic or genetic disorders if there's a known family risk. However, because it is invasive, it carries a small risk of complications, including pregnancy loss. The rate is generally quoted around 1%.
Oh, wow.
So nurses are absolutely crucial here in counseling clients, making sure they understand the benefit of early diagnosis versus that risk so they can make a truly informed choice.
And then there's amniocentesis, which I think maybe more people have heard of. How does that compare with CVS?
Amniocentesis, or amnio, is another invasive diagnostic procedure. This one involves withdrawing a small amount of amniotic fluid from the sac surrounding the baby using a thin needle inserted through the abdomen into the uterus. It's usually performed a bit later than CVS, typically between 15 and 20 weeks of gestation. And it's also used to diagnose chromosomal, metabolic, or genetic abnormalities by analyzing the fetal cells found in that fluid.
Okay.
Now, historically, amnio was also used sometimes later in pregnancy to check on fetal lung maturity. But it's really, really important to stress that routine use for FLM, fetal lung maturity, is no longer standard practice.
Why the change?
It's mainly due to huge advancements in using antenatal steroids, giving steroids to the mother to help mature the baby's lungs before birth, and just vastly improve neonatal care for premature infants. We don't need to rely on amnio for that specific question much anymore. The pregnancy loss risk associated with amnio is generally quoted as less than 1%, slightly lower than CVS typically.
Are there any other diagnostic tests out there for very specific, maybe less common situations?
Yes, there is one called percutaneous umbilical blood sampling, or PUBS. It's also known as chordocentesis. It's used much less frequently today, but it's still an important tool for certain complex, high-stakes situations. It involves actually getting a sample of fetal blood directly from the umbilical cord, again using a needle guided by ultrasound, usually in the second or third trimester.
And when would that be necessary?
It might be used to diagnose chromosomal or genetic disorders if CVS or amnio results were unclear or perhaps couldn't be obtained. It's also used sometimes to check for fetal infections or conditions like severe fetal anemia, where you need a direct blood sample. However, PUBS carries a higher risk of complications compared to CVS or amnio. Things like fetal bradycardia, a dangerous drop in the baby's heart rate bleeding from the puncture site, or even preterm labor. So it's really reserved for cases where the potential information gained outweighs those increased risks.
Got it. Okay, so beyond the initial diagnosis phase, there's also ongoing monitoring, especially if a pregnancy is considered high risk, to make sure the baby is doing well as the pregnancy progresses. What's the main objective of these antepartum fetal tests?
Yeah, the primary goal, the overarching aim of all antepartum fetal testing is really to proactively reduce the risk of permanent neurologic injury or, tragically, stillbirth, particularly in those identified high-risk pregnancies. It's about ongoing surveillance, being vigilant. And we have a whole suite of methods we use for this, things ranging from the very simple, like fetal movement counting, to more technological tests like non-stress tests, NSTs, contraction stress tests, CSTs, biophysical profiles, BPPs, modified biophysical profiles, MBPPs, and fetal Doppler flow ultrasound.
Okay, let's start with something almost every pregnant person is tuned into, feeling the baby move. What's the sort of official fetal movement counting method?
Right, fetal movement counting, or FMC, sometimes called kick counts. It's a very simple, total non-invasive method. The client actively counts distinct fetal movements. Often the guidance is something like the count to 10 method. The goal is usually to feel at least 10 distinct movements within a 1 to 2 hour period, typically done once a day. And this seemingly simple act is actually a really critical indicator of fetal well-being. A significant decrease in fetal movement can be an early warning sign of potential problems, like hypoxemia, reduced oxygen supply to the fetus, and it always warrants immediate medical attention. Don't wait.
That's really important advice. Okay, what about the non-stress test, the NST? That sounds fairly routine.
The NST is definitely one of the mainstays, one of the primary methods of fetal surveillance in high-risk situations. It uses an external fetal monitor, belts around the abdomen, to track the fetal heart rate and see how it responds to the baby's own movements. What we want to see is a reactive NST. That's the reassuring result.
And reactive means?
Reactive means there are at least 2 accelerations in the fetal heart rate within a 20-minute window. An acceleration is defined as the heart rate going up by at least 15 beats per minute above the baseline and lasting for at least 15 seconds. For babies under 32 weeks, the criteria is slightly different, 10 beats for 10 seconds. This tells us the baby's central nervous system is intact and responsive, and importantly, that they're well oxygenated at that moment.
And if it's not reactive?
A non-reactive NST means there weren't enough accelerations in that time frame. It doesn't automatically mean something is wrong. The baby might just be asleep. So often the next step is further investigation, maybe extending the test period, or sometimes using something called vibroacoustic stimulation, basically a gentle buzzing device placed on the abdomen to try and wake the fetus up and see if that prompts accelerations. If it remains non-reactive, further evaluation like a BPP is usually needed.
Okay, then there's the contraction stress test, or CST. That name alone sounds a bit more intense.
It can be, yeah. The contraction stress test assesses how the fetal heart rate responds to the stress of uterine contractions. Contractions naturally squeeze the vessels in the uterus, temporarily reducing blood flow and thus oxygen to the placenta. A healthy fetus with good placental function can tolerate this fine. The contractions are usually induced either by the client stimulating their own nipples, which releases oxytocin naturally, or by giving a low dose of IV oxytocin.
And what are you looking for?
We're evaluating the sufficiency of the uteroplacental unit, basically. How well is the placenta doing its job of delivering oxygen, especially under stress? A negative CST is the reassuring result. That means there are no significant late decelerations in the fetal heart rate following the contractions. A positive CST, however, is concerning. That's when there are persistent late decelerations with most contractions. This suggests the fetus might not be getting enough oxygen during contractions, indicating potential uteroplacental insufficiency. There can also be equivocal or suspicious results if there are some intermittent late decelerations, or unsatisfactory if you just couldn't get enough contractions to interpret the test properly. CSTs are used much less commonly now than NSTs or BBPs.
Right. So how do these different tests, the NST, maybe the CST, the movement counts, how do they sort of fit together to give a bigger picture of how the baby's doing?
That's where things like the biophysical profile come in. They often combine elements to give a much richer, more comprehensive understanding. The biophysical profile, or BPP, is a great example. It's a comprehensive assessment that combines that non-stress test we talked about with a detailed ultrasound evaluation. The ultrasound looks at 5 specific fetal biophysical characteristics: fetal breathing movements, gross body movements like limb movements, fetal tone like opening and closing the hand, and importantly, the amniotic fluid volume. Each of these 5 components, the NST plus the 4 ultrasound markers, gets a score, either 0 or 2 points. So the total score is out of 10, or 8 if the NST isn't done as part of it, which is sometimes the case.
And a higher score is better.
Exactly. A score of 8 or 10 is generally considered reassuring. Lower scores might indicate potential issues and require closer monitoring or even consideration of delivery. There's also something called the Modified Biophysical Profile, the MBPP. This simplifies things a bit. It just combines the non-stress test with one ultrasound component. The amniotic fluid volume assessment, usually the amniotic fluid index or AFI, this is actually a very common screening tool for fetal well-being. The idea is that the NST reflects short-term oxygenation status, while the amniotic fluid volume gives us insight into longer-term placental function and oxygenation.
Okay, interesting. And finally, you mentioned fetal Doppler flow ultrasound. How does that add to the surveillance picture?
Right, fetal Doppler flow ultrasound. This is a more specialized type of ultrasound. It's used specifically to assess the condition of the placenta and, crucially, the patterns of blood flow in the fetal circulation. We typically look at blood flow in the umbilical arteries, which tells us about placental resistance and sometimes the middle cerebral artery in the baby's brain. It's particularly useful in high-risk situations, like when fetal growth restriction is suspected, or in certain maternal conditions like hypertension. Changes in these blood flow patterns, like increased resistance in the umbilical artery or signs of blood flow redistribution to the brain, can be early indicators of worsening oxygenation or placental problems, sometimes even before changes show up on an NST or BPP. It allows for really timely intervention.
Wow. That was quite the deep dive into the world of prenatal diagnosis and fetal assessment. From the incredible precision of those diagnostic tools like CVS and amnio to the really comprehensive picture you get from ongoing surveillance with things like BPPs and Dopplers, it's just remarkable how much has advanced in helping ensure fetal health.
It is truly incredible, isn't it? Just the sheer amount of information that's available to prospective parents today. It allows for such profound insights into fetal development, potential challenges. These tools really provide a foundation for care, for planning, for making informed decisions in a way that just, well, didn't exist even a few decades ago. It's completely transformed the experience of pregnancy for many.
Yeah, absolutely. And that evolving role of the care providers, the nurses, the doctors, the genetic counselors in supporting individuals through these sometimes very difficult choices, like our source ebook detailed, that's just as compelling. It's clearly not just about having the technology, but about guiding families through what can be an incredibly complex and emotional journey.
Exactly. Which kind of leads to an important question, maybe it's something for you or listeners to consider. With all this information, all these options now available in prenatal care, how does this truly empower individuals and families? How do they make the best, most informed decisions for them? And, what does informed choice really mean in this complex, constantly evolving landscape?
Definitely food for thought. Thank you so much for walking us through all of that today. And thank you for joining us on this deep dive.